Good morning, everyone. Today, June 22nd at 8:07 Eastern Standard Time, I, Vishal Kapoor, would like to welcome you for another live case for peripheral intervention from Mount Sinai Hospital from New York City. Before we go over to the case, I just wanted to thank everyone personally from me and Dr. Krishnan's side for whoever got a chance to attend our CCVVC symposium or got to watch it live on YouTube. Thank you very much for attending. Please don't forget to download the CCVVC Symposium app. It's on the iPhone and available for you to look at the live cases which were done last week and from previous symposiums. Hope it was a great learning experience for us. It was like the best symposium presentation, especially the cases, the complexity, and little lumps and bumps which happened during the case, but the end results were very good. So now I'll let you go over to Dr. Krishnan, who has another fantastic case specifically left for post-live case for us to be seen. We'll let Dr. Krishnan take over and his team and let us explain the case. Morning, Dr. Krishnan.
Thank you so much, Vishal, and that was absolutely true. I echo your sentiments about us, doing really, it was just really a phenomenal symposium. And on behalf of you and obviously Dr. Guja as well, we would like to thank everybody who came. We had about 850 people come to the peripheral side, and it was a lot of fun. But beyond that, we have a really fantastic case for you, and I'd like to introduce my team. As you know, this to the right is Dr. Sachin Jain. This is he's graduating tomorrow, so this is his official last case before he becomes a full-fledged attending. We have our new fellow who's already here, and you'll be meeting him next week. Next to him, we have Ray Lascano, our interventional nurse practitioner. We have a new team today. We have some vacations and call-outs. So we've got Yoli, who's one of our very senior nurses in both TAVR as well as in peripheral as well as in coronary. Basically can do everything. And then we have Leora, who's again a very senior nurse who's actually been here for us for a long time. Actually, Yoli was one of those who trained me. Then we also have Damien, who's our brand new tech. Ricardo has moved on, and Damien has taken on and done a great job. So anyway, enough of the introductions. I really want to go to a wonderful, wonderful case that is going to illustrate some of the complexities that you face while taking care of the superficial femoral artery. So Sachin, do you want to present the case?
Yes, sure. Good morning, everybody. Today we have a really complex case. Our patient is 74-year-old woman presenting with the left leg lifestyle limiting claudication, Rutherford Grade II, Category 3, and Fontaine Stage 2B. Her past medical history is significant for hypertension, hyperlipidemia, chronic kidney disease. Her baseline creatinine 1.6 to 1.9, and she's a past smoker. Current medication includes Aspirin, Pletal, Plavix, Labetalol, Amlodipine and Lipitor. ABA was done as outpatient that showed on the right lower extremity 0.9 and the left is 0.5. Ultrasound was done that showed CTO of the left SFA, occluded ostium with occluded left posterior tibial and moderate stenosis present in both antitibial and also peroneal. So we did a diagnostic peripheral angiogram because of her chronic kidney disease. We did not proceed with intervention that showed a chronic total occlusion of the left SFA. The occlusion is at the ostium with 1 to 2 vessel runoff, and we staged her for elevated creatinine. And the plan is to show you, this complex case of left SFA CTO, and we will also get pedal access if needed. The AT is patent. Thank you very much. Back to PK.
So I want to play the film for Vishal and just get your thoughts, Vishal, on how you would handle this. I know you haven't seen the film yet, so go ahead, play it for me, Sachin. So I'm just going to go over the anatomy very briefly. So obviously creatinine is an issue, so the iliac has some mild stenosis. We didn't bother imaging it at this stage. So you can see you have an ostial occlusion of the SFA with robust profunda collaterals, and then next. And then you can see that the distal reconstitution zone is very deep in almost the P2 segment, P1 segment of the popliteal artery with a large genicular collateral that comes off right at the spot. Then you can see the runoff is really predominantly by two vessels, both the anterior tibial artery and the peroneal artery to the foot. And obviously, for the sake of contrast, and we've had diagnostics in the past, we stopped there. So, Vishal, I just wanted to talk to you about, how you would approach this, and then I'll just go over what's going on with, what my thoughts are as well.
Well, I mean, it's a very, very complex case actually to begin with. Keeping in mind the SFA origin, I mean, it's very hard to see it here, but I would probably pray and see, hopefully I find a nub. So I might go maybe a steeper ipsilateral, in this case more LAO to and mag up to hopefully define and hopefully find the nub or the ostium of the SFA. If I do find it, then again, using the angle word tip catheter with an 035 stiff glide wire, I'll try to poke around and hopefully try to pass the lesion. In case where we really cannot find the nub, there are, I guess, two ways to approach it. Either some people will switch over to a pedal axis, like you said in this case, if needed, like Sachin said, and then try to go retrograde and hopefully recanalize into the SFA. The other approach I would probably begin with, because we already have an antegrade or an up and over axis approach, is to try to, if for some reason cannot find a nub, try to feel the nub with the catheter itself, like the grooves we usually do, and keeping in mind the anatomy and the feel of the catheter itself, we probably might be able to find the ostium and try to poke around and see if the wire goes in the right direction. So it's a very tough case, actually. I mean, in this case, we really don't have any real support of the ostium. So even if you try to poke around with the wires, especially a stiff wire, it might kick our catheter and wire out. So if really bad, start with an 014 or 018, like a stiff wire, and see if you can find a nub and try to wire it down and then exchange for stiffer wire. So
right. So I think you hit on all the points, but and I think that's great. So I think for the audience out there watching, I think the first thing you need to do is start to identify what are the problems you're going to face in this, right? So if you break it down and you start identifying the problems, the first problem you're going to face is finding the ostium, right? So two things you can do. Did we take a groin shot on the other side? Yeah. Okay, so go back to the groin shot.
You didn't take.
Oh, you didn't take one. So one thing you can do is go to the contralateral side and look for the groin. Okay, if you look at the groin shot on the contralateral side, it'll give you an idea of whether the takeoff was high, whether the takeoff was low, whether the takeoff was near the profunda, whether it was near the ostium of the profunda, whatever it may be, anterior takeoff, whatever takeoff. So that'll give you one clue. Second thing you can do is come off roadmap here. Second thing you can do is to mag up real high, and then on Decini, look for any calcium. So, am I on? I'm on, yeah, okay. Oh, yeah. So when you see, you look for calcium, and you look for a calcium track, okay, all the way down, see if there's any SFA calcium at all. And of course, as luck would have it, there's really very, very, very minimal calcium here.
Right.
So that's another thing, you can always trace it back to the ostium, okay? The third thing is what you said, is to go ahead and probe the SFA with the catheter. Fourth thing you could do is use external ultrasound to identify the ostium of the SFA, find the occluded SFA, trace it up to the ostium, track the catheter, and then go ahead and enter the cap with the catheter. Fifth thing you could do is go to the runoff. Fifth thing you can do is, if you can't find the ostium, is you can go ahead and look whether you have an above knee SFA at the level of the adductor canal. At that stage, you can do a direct SFA stick, and then you can go ahead and advance a wire over an 035 glide wire up to the ostium, and then you can try to go from the proximal and try to meet the two in the mid. So that's the fifth thing you can do. The sixth thing you can do is, obviously in this case, since you don't have an above knee SFA to go after, is to either go popliteal access or you can go pedal access. So we're prepared to do that. So I think the first thing as a physician, when you see these type of lesions, you need to have an algorithmic approach on what are my challenges with this case. So the first challenge is engaging the SFA. That's probably the largest challenge. The second challenge will be transversing this lesion. Third challenge will be re-entering the lesion, because very diffusely diseased distal popliteal, where you're going to have to get into. And the fourth will be your final therapy, which we'll do if we're able to get through the first three challenges. So as far as equipment here, we've got a 7 French pinnacle destination sheath. We're up and over. Our nurses have given bivalve Rutin, which we normally do in most of these cases. Patients loaded with Aspirin and Plavix. And now we've got our Aqua Tempo here, and we're going to go forward. So what I'm going to do is, just for the sake of purposing for teaching, I'm just going to go with a roadmap here. Roadmap, guys. And I'm going to have Ray inject through the main catheter, which is the sheath, so I can fill most of this vessel. Inject. So you can see here, injecting through the main catheter helps you as well to see what may be the nub. It's very hard. There's absolutely no nub here. So, I'm just going to poke around as I always do. Now I'm going to take come off Ray roadmap. Okay, and I've got a saline loaded syringe here, and I'm just going to inject here. Let me see. So that's, possibly that's it, right? So now what I'm going to do is I'm going to get an 014 WIN wire. and I'm going to go with a wind wire, but you know the wind wire that I use, guys. So we're going to go with the wind wire, and we're going to go ahead and try to actually feel this nub. Now we don't have an external ultrasound prep today, so you know that might have been a wise thing for us to do to simplify this case. But we'll go ahead and just use a wind wire and just kind of poke around and see what we find.
Just a quick question, I guess it's probably just thinking, extrapolating a coronary stuff. Do you think use of IVUS would help you identify a branch? Let's say you IVUS into the profunda. Do you think that will give you any additional benefit or advantage?
We've tried that in the peripheral, but you really need front-looking IVUS here, you know. I think forward-looking IVUS would really help. Unfortunately, they haven't made that yet for us. Give me a little die, guys. Just want to make sure I'm not dissecting into the profunda, which I'm not. So, you know, I don't know where this is going, guys, but, you know, at this stage, it's a small perforation if I've created one. And you know, the issue is you really want to try to get these micro channels. You know, sometimes you have these weird micro channels here, and that's starting to look a little bit more promising. You know, so, you know, now what I'm going to do is I'm going to go AP.
What anticoagulation are we using?
We're using bivalrudin, and, you know, we've done a lot.
Right.
You know, so what I may do here is, for the sake of not creating a large perforation, is go ahead and use a 018 catheter, or maybe I'm just going to go with what I need here, which is just shove this catheter in there and then decide what the hell we're going to do here. Let's see if it even goes. You know, it doesn't seem to want to go here. Nope, it doesn't want to go. So give me an 018 Trailblazer, guys. Actually, you know what? Rather than a Trailblazer, you know, give me a Trailblazer. We'll go with a V18 here. We'll show a different form of crossing. So we're going to go with a V18 and a Trailblazer. It looks really lateral to me here, but I'm okay with that, you know. I think it should be okay. We're probably extraluminal for part of it, and, you know, we're going to be okay, I think. We'll figure it out. So this is, you know, part of the kind of the way we want to do it. So what I'm going to do in the meantime is I'm going to ask Ray to go LAO again. And I'm gonna use my noggin and say to myself, okay, where do I expect this SFA to be? And does this look like an SFA? And I always talk to my fellows about knowing the anatomy and where the arteries should be. Yeah, there are anomalies, I agree, but not many SFA ostial anomalies. So in the tibial area, I completely agree that there may be a lot of anomalies. So I'm just gonna have Ray just give a little bit of dye. We dilute our dye 50-50 for our, actually give me a roadmap, Ray. So we're gonna go ahead and give a real roadmap, and I'm gonna assess where we are. Oops, let's do it again. No te mueva, mama. Okay. See, that looks like the SFA to me.
Right.
So, you know, that's kind of where I expect the SFA to be. You know, I'm not exactly afraid of this, but, you know, even if I perf with maybe a little branch perf, and I can always coil it, or I can do what I need to do, it's not going to be the end of the day.
Right.
So, you know, and if I'm not certain, I'll definitely ask Yoli to turn off the Angiomax, you know. So give me a V18 wire here, guys.
I think you made a great point regarding
V18.
knowing your anatomy from the
V18?
other, knowing your anatomy from the other side, because most of the time it's like a mirror image. So knowing the anatomy on the contralateral side gives us a rough, decent idea of how the SFA on the other side would look. So I think that's a great point to begin with, one of the markers which you can use.
Yeah, so Sachin just told me that there's a stent at the other ostium. But, you know, here, you know, we already have kind of figured it out.
Right.
Maybe dumb luck, maybe not, who knows, right? We figured it out. So I think now we're just going to go forward with this. You know, once I get comfortable with this, then we can start thinking about, okay, what's our definitive therapy? So, you know, we normally, as most of you have seen us do our SFAs, we don't use 18 wires in the SFA. But I think, you know, it's a reasonable thing. You know, Andre and Dirk and a lot of our operators here in the US use V18, 18 gauge wires in the SFA. Off-road map, guys. And I think it's not a wrong thing to do. So I would never discourage anyone from using it. I just think that in this stage, you know, I'm just going to kind of let the 18 gauge wire do its work. So now, you know, if I'm able to get a loop, I'm happy. I'm not happy with that, obviously, and that's another problem. You know, you don't want to go perf some benign collateral. You know, who knows what that is. If I can get a loop, I'd be really, really happy. There you go. So I got a little bit of a loop there. So, you know, so I'm going to loop it down. You know, you could say, well, Prakash, why'd you get a loop? You know, because look, there is, you know, intraluminal crossing versus subintimal crossing. Is there really a value? I'm not sure, you know. So, you know, we're just going to go like this all the way down.
Looks very promising.
Well, yeah, you know, and again, the same thing. You want to look at the actual gauge of your loop and the pathway that it's taking. You know, that's awful large right there. But you know what? I'm going to go ahead and just kind of take it for whatever it's worth. Push it down.
And you're right on your calcium
my
right
patient is not in pain, so now that I got a little bit of calcium to deal with there, so this is going to be, again, a difficult thing. So now I'm kind of anticipating the problem I'm going to have distal, which is going to be to re-enter this vessel, which is going to be a real problem for me. So I already have anticipating my next step, which is what's happening distally. And you can see here, this is going to be a major pain in the ass. I'm just making sure that she's not having any pain or anything like that. So I'm going to go ahead and take this loop out a little bit, even though it really goes against what I feel, and try to see what I can get through. And you can see I'm not able to poke through this calcium, which is not a good thing. So at this stage, there you go. So now I'm going to leave that there. I'm going to track this down, pull my wire a little bit to make it, there you go. So get it down into that area, right? Now I'm going to go ahead and try to advance this and then advance it down. See, so this is kind of, how you want to do it. You don't want this to go any medial, and this is very important. So now's the stage where you want to look at your distal reconstitution carefully and make sure that you're heading in the right direction. Seems to me I'm too medial. You agree?
Yeah.
Yeah, it looks a little too medial, but let's go with the distal reconstitution shot here. So roadmap. So inject. So these are tough cases. These are very, very difficult cases for us to really kind of just judge. Actually I'm not too medial.
I think you might be right because
I think I'm doing okay.
Calcium, so I think that's
I
a great
think I'm doing
marker.
okay here. So let's come off roadmap. See, the dreaded issue here is if this wire just starts to go more and more medial. How it's looping right there, you see that?
Right.
I do not like that at all, So I'm going to lose this loop here, see whether I can just take it with a straight catheter, and obviously it's not, So I may actually now change that to a Confianza or a wind wire. And then I'm going to try to see whether I can just wire this normally. Normally, like I said, this is not really how we do it. This is an old occluded SFA, very, very, with some calcium that's obviously I can feel now with the push of my wire. I feel like I'm right now in the region of the adductor canal, but can't be sure. So right now I'm starting to think about my next step, and my next step will be, okay, if I'm not able to get this down, what is my next step here? There we go, a little bit more progress there. Let's see whether I can get this a little further. I don't like that, So, I definitely don't like that. So there, I had it going the right way. So, you can see the calcium level here is not a very good thing.
Yeah, there's calcium marker at 32 and 33, so yeah, almost.
Yeah, see that?
Just deflect, yep. It deflects
It's very
off.
medial here. There you go, there you go. A little bit of love there. Get it down there. Okay. Show me down, guys. Okay, give me a roadmap here, please. Let's see, let's look below and see whether we're heading in the right direction. Roadmap. Inject. This diffusely diseased popliteals, you really have to be careful. In my career, I've run into trouble with these diffusely diseased popliteals. Like there it is. You see it right there? Like there's a collateral, and then I don't even know which one's the pop here.
Right.
So let's just take a better picture here. Go a little lower, Matt, guys. Okay. All right, DSA, guys. So we're going to take a full picture here for us to see where we are. All right, looks a little promising, right? So that was kind of where we should be heading. So again, I'm going to go back on coronary here. So basically, we made a lot of progress in this case in 10 minutes, but we're far from getting done. We know the next challenge we're going to face is going to be trying to get through distal cap.
Right.
So now I'm going to try to advance this, and I'm having trouble advancing. There it goes. Okay, good. And then I'm going to try to free up my wire here, which is stuck to my vessel. This is also a very common thing where the wire gets stuck, and then just pull it out of there. Give me a Terumo G wire, guys. Gold tip.
So after crossing your hub, the origin of the SFA, would you ever think about just switching over to your 035 system and just going down like you would do another SFA?
If you look at that diffusely diseased popliteal, that popliteal is going to give you a lot of trouble.
Right.
To really re-enter that. That popliteal, I can tell you, is going to be trouble. I mean, so the idea here is, I think personally, you have to have a low threshold for going with a re-entry device. So when you go with the re-entry device in the popliteal, obviously you're going to have a level of confidence in terms of how to use the device, and also in terms of your landing zone where you're going to re-enter and how far you're going to have to stent. So at this stage right now, we've gone pretty far subintimal for sure. So now the issue is going to be is whether I'm going to have to extend this plane distal. The other thing you could do is come from below now with below access if you don't succeed this side, and then really try to advance the wire from below, and then try to do a balloon technique from above and below, and see whether you can get in that way. So obviously here we're really struggling here to get down. I know. I don't think she's having pain here, but let me see, just get this down a little bit more, a little closer, right? And then let me see whether I can track this balloon down. Nope, this is not going either now. So that's another problem, is trackability of these devices. So show me down below, guys. So let's go to an angle so everybody can see where we are, and then we can assess our pop as well, and then decide whether we're close, not close. It looks like we're not going to be close. I don't think we are. Roadmap. Okay, inject. Of course, she has to move when you need her not to move, right? So,
it's right on top of it.
Looks like we're pretty close. Let's do a DSA. Ready? Señora, no te mueva. All right, so we're getting close, right?
Almost there.
So remember, this is what I mean by that diffusely diseased popliteal. You see how diseased that is? So that popliteal is an issue here. So I'm just going to try to just kind of get it in there with this, see if it just happens to slide in with a little bit of dumb luck, as they say, right? Well, now this is very diseased, so it's probably not going to go. So now I'm going to try to get some head of speed here and see if I can go. Obviously, the Terumo G wire is a good dissection wire, but I don't know if we're going to be able to get this 018 catheter down there really fast. Let's see.
Just for the audience, I want to know, how aggressive are you in using your re-entry devices, specifically in the popliteal, with, going subintimal and the aneurysm? You know how people talk about pseudoaneurysms and aneurysm at the popliteal level?
Well, yeah, you have to be aggressive because the old saying is either you're going to shit or you're going to get off the pot, right? The point is you're already here. Pull the wire a little bit. So the issue is, if you're close enough, I think it's worthwhile, but right now we're not close enough for sure. So the other thing now is to wire it now that you have a plane in a standard way. So put the torquer back on. Let's see whether we can wire it. And the other thing you got to start thinking is, what's your equipment now? Now you have an 018 catheter that's not tracking. Do you have 018 balloons, or are you going to switch to an 014 wire here now? That's the whole idea now. You got to start figuring out what's your plan of action here. You can see here that obviously you're very subintimal. Let's see whether this is starting to head in the right direction. I hope it is. Nope, it's not, as always. And let's see. So this is certainly, there it is. So
there it is.
I don't know if we're in, but. So the issue just becomes, is, are you going to be able to get this into the vessel? You're not in there. Are you going to be able to get this into the vessel? So it's not tracking at all. So the issue now is, do you want to switch out for a V18 and then try to get this even closer? But it's not going to track. Give me a V18 wire, guys.
Yeah, I'll probably use a V18C, and then otherwise then switch over to a long, like a balloon, and create a little bit of track in the subinterval plane. And
right. So we have to look at our 018 balloons. Damien, can you look at our 018 balloons? I think we have some Armadas up there. Armada 018's way up there. We're gonna start to balloon the track on the right side, all the way up top in the box. Right side, right there, the green box. See, not only am I operating, I'm also managing equipment in the cath lab today.
Well, that's why you're the director of endovascular, right?
Yeah, it's a prestigious job, right? So now we're gonna go ahead with a V18. I need a new V18, guys. Okay.
I think you are, closer to the popliteal, so I'll just probably put the V18 down to the pop, another DSA, to see how off you are, and if you're comfortable, just balloon the track and use a re-entry and get back into the
Give me the
popliteal.
Confianza then. The other thing we can do is also is to go ahead and try with the wind wire a little bit more from this end and see whether we can steer it in with a steerable coronary wire. But clearly I'm going to have to balloon the track, and that's another thing I don't want the audience to be afraid of doing, is to balloon that track. Because if you balloon the track, you're able to reduce your tension on your system, and you're able to go ahead and get through. So let's see. I mean, I think the first challenge, we've traversed the SFA quite easily. We've identified the cap. We went over how to identify, how to identify the cap. And now, I thought we were through, but we're not that good, are we?
Oh, it's possible.
You are. No, we're definitely not through. Okay, let's take a DSA shot here, guys, so we can see where the hell we are.
You might be in the collateral. I don't know.
I hope so. I'm praying. It's always good. That's it. So we'll see where we are, and we are in the collateral, as you did say. So it's interesting, or we may not be in the collateral, but I'm going to pull it out because that's not where I want to be. And I'm going to immediately point the wire over here. And try to, it's looping on me again. So this is the area where we're not able to get it really close at all.
Yeah, that.
Yeah, but it's going medially.
Right,
You see that? It just jumped on me.
That's true.
Let's do a roadmap here, Ray. So again, while we're watching paint dry here, let's see whether we can probably plan for a pedal access very quickly. And of course, my young lady has to move with her high creatinine as I'm trying to figure out where I am.
I guess the biggest learning point in this case is to keep knowing where you are by your feel and by angiographic as well. So like you're doing your repetitive DSAs and roadmap, that gives you a very good idea of if you're in the right track, if you have to go back, rather than going all the way down and then realizing you're in the wrong path at all and then coming back up. So that's one of the great learning points from this case is you have to visually and of course by tactile sensation know where you are and change your plans accordingly. And there she moves again. Yeah, that looks like a better direction. Oh, yeah.
Definitely not. Oh, we're definitely out of this vessel.
Oh, yeah.
All right, so let's get pedal access here because I think it's very diffuse. And then try from below. So let's get some pedal access. Señora, no mueva su pierna. Muy importante. ¿Dolor o no? No. Then no mueva. All right, let's see. Okay. So we've prepped her leg completely, and I'm just going to go ahead and just go ahead and do it with ultrasound. The problem is we don't have power Doppler here like we did for the live case.
Yeah.
You want to do with ultrasound? Is that what you want to do?
No, we can do it.
Okay. It's up to you. What do you want to do?
Creatinine is elevated.
Okay, so Dr. Jane is going to demonstrate ultrasound access here, so we'll go ahead and get ultrasound access. If not, we'll just go ahead and do it with fluoroscopy. So, this is kind of where you want to be prepared, right? So down below, you're not getting through. Go through the angiograms, Ray, for me. Down below, you're not getting through. So now we're going to start from here, and then we're going to go ahead and do this case. So the idea is, okay, like you said, you don't want to dissect too far into the pop. You're going to have to stent the pop. You already have decided,
right?
Because there's really no choice. Okay, and then now you're going to go ahead and look at that DP where you are. So you want to get access, not at the level of the foot, just slightly above that area, right in front of the tibia, so you can actually go ahead and compress. Two things you need to know is the anterior compartment is more prone to obviously having, compartment syndrome. So you really, really want to identify what you're doing and get a good stick here. So he's just going to go ahead and find the artery and the vein, and the artery and the vein generally will lie side by side. So he's searching for it as we speak, and if he doesn't see it, obviously I'm an old school guy, we'll just go ahead and do the usual way we do things. So there's the vein. You can see the vein is compressing, and right, that's the vein right there. You see how it compresses,
I guess
guys?
now we see it.
So that's the vein, and right next to it is the artery. You can see how close the vein and the artery are there, and I don't think the artery is pulsating. Do you see it pulsating? No, the artery is not pulsating either. So that's clearly the vein, but he can't really see the artery, can you? I don't really see the artery very, very clearly. So he's looking for the best spot there. I think on On this, on the 9 o'clock side is the artery on top, right?
No, it's actually at the,
That's the artery. You can't compress it. See? No, so you're compressing that.
That's just too much pressure, though.
That's a lot of pressure. That's the artery right there. See that big round thing? You see it now?
No,
Right.
regular one.
Regular one. You see it right there, Sach?
Yep.
You agree with that?
Yeah.
Or is that a lot of pressure that you're compressing?
That's a lot of pressure.
Okay, a lot of pressure. Okay. So now we don't have Doppler in this. If we had Doppler, it'd be a nice thing. But remember, even if you hit the vein, it's no big deal. I mean, you hit the vein, you just pull it out, you just redirect and hit the artery. So we're just going to go ahead and give a little lido and then decide. Okay? So he's going to give a little, Señora, poquito pincha en su pierna. Okay? No mueva su pierna, por favor. So one of the things, arguments is in these kind of cases, well, he's a claudicant, why not a bypass, right? So,
Right.
so you know, listen, I mean, bypassing for claudication in today's day and age, most surgeons would not do it. We can safely get pedal access, go through, recanalize this vessel, and then go ahead and take care of it. So I'm watching his needle for any ideas of flashback. So there he just
There he poked it.
well, it looked like he had poked the vessel there. So we're not seeing any blood. So we'll see whether we see any blood in a little bit sooner.
there. Oh, he pulled it out.
Yeah, he just pulled it out there. But remember, you want to get an anterior stick as much as possible, right?
Yeah.
And, you know, you want to be right there. That's a good spot to enter the vessel. And try to go a little deeper there. Nope. I think you're on the side of the vessel.
Yeah, his vessel is rolling over, so he's on the side
Yep.
of the vessel.
Let's see what he does.
Still has to go a little bit more medial.
I think you're through and through now, right? You can
Yeah,
see it.
I'm not getting any blood back.
Yep, I can see that.
Yeah, because you're probably on the side of the vessel and he's
Are you
in the
compressed?
posterior wall. That's what it is. Yeah, that should be a little better.
But we're not getting any blood back. Well, without blood, you're not going to advance a wire.
I think it's the calcification that's just taking you off the vessel.
Yeah. No, I'm not getting any blood back.
I would probably change the angulation, Sachin, and just go a little bit more. Yeah,
Yeah.
you're way too
So as you can see, you know, these things take a little bit of time if you want to enter it properly. So I'm going to give him a few more minutes and then I'll just go ahead and do it fluoroscopically. Hopefully we get right in. It's not easy, but you know. You should be hitting, if you're hitting a vein, you should get some blood back.
right.
Yeah, nothing is.
Nothing, you want me to do it?
Yeah.
It's probably hitting
Fluoroscopy?
the posterior wall. That's what it is. So you can see the artery not bent completely. Yeah, there.
Right there, that's it. I think that's it. For sure, you can see the calcification.
It's the,
Yeah,
si-
but no blood
it's the
back.
side wall.
Okay, so let me take a whirl at it. It's not easy. So, let me get a little gum. All right, here we go.
Wait, that's a big calcium.
Now that's probably the vein.
That's the vein.
Yeah.
We have a lot of veins here, which is a problem.
Yeah, and right there the artery is just medial to it. Next to it, right at 2 o'clock, 1 o'clock, whatever.
The really small thing, or that
Yeah.
We can go a little bit anchorize.
Oh, that's way too off the.
that's the vein.
Right next to it at 2 o'clock, right above the vein.
Mm-hmm.
It's not that circular because I think your angulation is not that stuff, but yeah, there. Now you can see it more circular and well defined.
Nope, I'm way off.
That's the other side.
You can get here. Okay, go back to you, what works for me. So we will do the usual way. We need to get a better ultrasound machine. Bring it closer, guys. Raise the table. Okay. Okay, roadmap here. Leave that on, guys. Don't pull this off, just in case. There it is. Barely. All right, let's do another quick. Okay, now I know. Inject fully. Okay, right at the level of the ankle. Okay. It's the flow is so bad.
Right.
That's the problem why we're having a lot of trouble getting in. But I think we need to get a better ultrasound machine here at Sinai.
So you hit directly at the distal tibial level for the AT? Is that your landmark? The
Well, I'm
landmark?
trying to, but you know, it's hard in this situation because the flow is so bad, and that's why she's claudicating so much.
Right.
That I think we need to go to different angles here. So you can put me on coronary here. So I'm going to see how that needle looks in reference to where the vessel is going to be coming. So that looks good on that side, right?
Right.
I'm okay there. Now let's go to the opposite side. You want to go to two different views and really kind of see where you are. And then you want to see whether you can just kind of poke it right in if you can. There it is, I'm in.
Yep.
All right, give me the wire now.
Great.
So we'll see whether this is the one.
I guess this is, again, for the audience, it's just a, the 1, 2, 3 of endovascular. It's a two-dimensional visualization and working in a three-dimensional view. So like Dr. Krishnan said, get two orthogonal views to define your arterial layout, and then go fluoroscopy if you're going, and then hit stick. Of course, you want to try the ultrasound and see how it works, but sometimes like PK says, the old-fashioned way is the best way, and this is what it is.
I mean, I'm an old man, I've been doing this for a long time. So, I think this is it. I mean, I may not be it. We watched Andre demonstrate in our course the same thing, it looks like it's definitely the artery. So what we'll do now is we'll just take it up to make sure it's the artery. Looks like it's the artery, got a little branch there.
Right.
And then we'll see where this goes. So I'm just gonna,
No.
I'm gonna do a DSA here just to make sure I'm in the artery. DSA, guys.
Yeah.
So this is a good example of inject, how this works. Hopefully we're in the artery. If we're not in the artery, we'll just reorient and hit the artery the next time. Looks like we're in the artery.
Yep.
Okay, everybody agrees?
Yep, looks
All right,
good.
we're in that branch. Everything looks really kosher here. So now we're just, what we're gonna do is we're gonna put a dilator in. Okay, so we're just gonna put a little dilator in here. And then over that, I'm gonna advance the wire, the V18, over an 018 catheter. So we don't actually get access. We just put a short dilator in. Can I have a stiff one here, guys? This is not stiff enough.
Is it the micropuncture
Can I get a
dilator we're talking
stiff
about?
micropuncture kit, please?
Oh, okay.
So I'm just going to use a stiff micropuncture dilator, and I'm going to go. So this is another advantage. I mean, look, you got to be able to be flexible. You have to be able to use ultrasound. I mean, a little bit of a dinosaur where I'm not, I don't have a good ultrasound machine because I rarely use it. But I think in the modern labs, you need to have a power ultrasound and a power Doppler to be able to see all these things. So we're just going to go ahead and put this one in now. And once we put this in here, we're going to have continued access into this vessel. So all I've got is a little dilator, okay, which is just going to go in this vessel for me. I'm going to go ahead and just, get it in there. And then once I'm in this vessel, deep enough, I'm just going to go ahead and I'm going to give my nitro and the other antispasmodics, guys. Can we give some of those as well? Yeah. So once we give our nitro cocktail with verapamil the way you do with radial intervention, we're just going to now go ahead and do the intervention. So bear with us. You know, these are difficult cases that take a little bit of time. So we're just going to go ahead and give our nitro cocktail to avoid spasm. But remember, we're going to remove this very quickly. We're going to go ahead and put our V18 wire in here. We're going to go ahead and put our 018 Trailblazer or Quick Cross or whatever, CXI catheter through here. And then we're just going to go ahead and do our work through that, allowing it to bleed. So we're not going to be completely occlusive. So now I'm just going to go ahead. Now the anticoagulation we chose, I'm doing the whole thing?
Yeah.
So the anticoagulation we chose is going to prevent us from having any thrombosis issue. And as long as I don't do anything crazy here, I think we should be fine. So I just pumped in my cocktail. Sachin, could you tell them what the cocktail is?
It's a 2.5 milligram of verapamil and 200 mics of nitro.
So it's going to go in to prevent any, God forbid, any spasm. So now give me my V18 wire now. So I'm going to go in with my V18 wire from below. Now remember, I have a V18 wire from above. So I've got 2 wires here. I haven't done any ballooning from above. I've just got access and I'm near the vessel. So now what I'm just going to do is I'm going to use this as my ability to go ahead and get up to the level of the popliteal. V18 is a good wire. It's made by Boston. You can also use the command. What is that? Abbott wire, Sachin? The Connect. You can also try to use the Connect. That's also a very good wire as well to try and get through these lesions. So we're just going to go ahead. And again, in the tibial, guys, I want you to always do it on fluoro. Please do not advance these wires blindly. You know, just do it on fluoro. Be extra careful. Patient is a claudicant. They are not CLI. Okay, there you go. There's an example of getting where you shouldn't go, right? And still getting where you shouldn't go. The only question is, do we have an occlusion here, which I hope we don't. I don't know, Sachin, do we have an occlusion here?
Doesn't look
okay,
like
we don't have an occlusion here, according to Sachin, which makes me a little bit happier. And then well, it's behaving like an occluded vessel. I hope I'm wrong. I think I'm wrong. Sachin, am I wrong? I hope I'm wrong.
Yeah.
So now you can see I'm taking it back from below, and I'm almost meeting the wires. So off-road map, guys. I mean off this. So what I'm just going to try to do is just try to advance this. I know I'm in the vessel below, so let me just try to advance it smoothly. There it goes right into there. So I don't know where we are here. We're somewhat close. We're somewhere not close. I'm not sure. So we're just going to leave it here, and we're going to take a picture. Ready? Go ahead. So it looks like we are in the true lumen here, and we're probably not in the true lumen above.
Right.
So what I'm going to do is just pull my above catheter back, right? Just continue pulling it back, right? Let's stop over there, right? Now I'm gonna just try to advance this from below. Remember, this is the area where I was having trouble, right? So I'm just going to try to advance this blindly from below, right? And so far so good, right? So now notice I hit the other catheter. You guys notice that?
Yep, it
All
moved.
right. So now what we're going to do is we're going to go ahead and take out and load the V18 from below, right? So we're going to take this, my dilator out as I promised, and then I'm going to go ahead and take the V18 from below. Here's the 018 V18 going down below. Now remember, guys, I mean, it's just thought processes. It's not difficult. Anybody can do this. It's anticipating and not spending your entire day doing an SFA case. You know what I'm saying? You really want to be clear on the challenges that you're going to have in this case and be ready to tackle those challenges very, very quickly. So you can see here now we've tackled this challenge. We've crossed. We anticipated all these things. Now Ray is going to give me a rail.
What support catheter are you using from
We're just
below?
using a V18 here, Vishal.
Oh, no.
I'm so sorry,
Trailblazer.
a Trailblazer,
Okay.
forgive me. So, this is where it's going to help me to push this because I'm going to have a little bit of support, and the support catheter is coming from below. So right now I can do a reverse cart, I can do whatever I want, right?
Right.
So now I'm in the SFA, which makes me a little bit happier. So I'm going to pull this wire back here, right? And then I could try to be fancy and wire it and do things. Let's see what I can be fancy. I've never been fancy before, as you know, but let's try to be fancy. See, let's see whether we can get it in there. Look at that. I think no, we're behind
right
it,
behind
right?
it. Yep.
So which is fine. Let's keep going up here. I'm going to just keep pulling this back, right? Right. Let's keep it right there, and then let's see. See how much easier it is to push from below, guys, right?
Yeah.
It's just so much easier. The cap is so much better, right? You know, just kind of keep coming up, just keep coming up. And remember, these are areas where we were worried, right? So why don't we try to wire it from below into this catheter, capture it, and see what happens, right? So why don't I pull this back here, right, to this area. Let's look in two different views. Looks like this is the area where the closest to this catheter, right?
Right.
So let's leave it right there. Now pull this catheter back, guys. I mean the wire, I'm so sorry. Pull the wire back, And give me like a coronary wire that I can use to wire. Give me like a fielder or something. Let's see whether we can get it in.
So I think that's a great point. Pulling and pushing your wire simultaneously to keep a track of your the previous course and just giving you a very good idea of where you actually stay.
Yeah. So Ray just handed me a command wire, which I think is the right thing.
V18.
And so now we're gonna mag up real high here. Obviously, it's a very small hole, and it's going to be difficult to get, but say some sort of luck we get it. It'll be nice. Show me higher. Because remember, you don't need to show me below, because once this enters, if the catheter from below, the V18 from below moves, then you know that there's a problem, right? So that's interesting. What happened here? Oh, I came out. I'm sorry. Oh, it's all the way down here.
Yeah, that's why I thought the drill buzzer.
There you go. Forgive me, guys. So let me just move this up. So the pushability factor is decreasing, obviously, but we're able to get it up. Let's just see whether I can just go from below. If not, we can always snare it from above, right? This is truly a needle in a haystack.
It's right. No.
We're just in a different plane.
Still off, yes.
So remember, this is the area where you can actually do reverse cart. It doesn't really matter. Nope, we're behind it. So give me a confianza from above, guys. The other thing we can do is try to come from above with a confianza, right? Or
go down into the other
win
one.
and try to get it into the bottom one
Right.
below. So if not one, why not the other, right? That's the way I look at it, right?
Correct.
So let's leave this here. So again, now anticoagulation is not a problem, right? I've got my anticoagulation strategy is good, right? And what I'm going to do is just try to wire from above, below, or whatever it may be. Okay, good. Just give me a slight curve here. So now what I may do is I'm going to ask for a Terumo Navicross. Don't open it. And what I'm going to do is I'm going to put it from above. And notice, see, the whole idea to keep these cases moving so Yoli doesn't get upset is to be thinking about the next step, right? So right now I'm thinking about the next step. So my next step is, what am I going to do if this doesn't close? Well, I know I'm next to one another. There's no reason for me to do a reverse cart. I'm going to try to go with a larger catheter from above and try to wire it. Maybe this is just too difficult. No, you can just show me down, yeah. So I'm just going to wire, no, right there, right there, a little higher. There you go. So, you know, maybe the larger catheter from above may be enough here to be able to get in. It looks like we're in two different planes here. Yep, we are definitely in two different planes.
No, you have to start from below 15 is your first marker for the other catheter. So you have to come back a little bit.
Nope, not there.
Other mark.
One marker up. PK.
Oh, I'm so
right
sorry.
there. Right.
Oh, thank you, Chief.
Yeah, right there. So let me ask you a question. Would you ever start this?
Notice I moved that, Vishal.
Yeah, yeah. Would you ever start this case as
See
a
that?
pedal axis?
See that? Look at that. Look at that.
Right there.
Hello. How are you? See that? We're tickling it. This is like my 5-year-old when I play with her, you know? See, Ray gets crazy when I say these things. Anything, Vishal?
Would you ever get a pedal? Would you ever start this case as a primary pedal case? Oh,
I think
there we are in.
There we are.
Beautiful.
I think we did it.
Yep.
So now we're just going to pull it down, right? We're going to go all the way down. Oh, hello. We're meeting this one. Ray, pull that wire out, please. So we crossed. So now what we're going to do is, just to be careful, we're going to walk this wire all the way out, right? So we're gonna low mag it. So I mean, Vishal, I mean, you know, look, you know, these are not difficult things. You know, I want everybody at home to really know that this is not difficult. You can easily do this. You know, it's not at all. Show me out, guys. It's not. No, meaning out below the foot.
Yeah.
So we're gonna just bring it out through the catheter. Show me the catheter here, guys, so the audience at home can see this. Right. So let's see, it's gonna come out this end here. And there it is. Just now pull that catheter out now. Just walk it out. Just pull the catheter out. Just pull. Yeah, I got the wire. So now he's just pulling the catheter out. Now see how it's at this end here? So now this is the Safari, no big deal. Everybody does it, right? Nothing to write home about. So now what we're gonna do is we're gonna put a clamp here so we don't lose this wire. So we're gonna take this clamp and just throw it here, right? So we're not going to lose this wire. Whoops. I don't know what Sachin gave me. He gave me a very poor clamp. Let me put it right here.
Come in the kit.
Yeah, there you go. Maybe a straight. Do we have a straight or no?
Yeah.
So put it somewhere here so I don't lose it. Make a big loop and put it. Actually, don't make a loop. Yeah, just put it there. There you go. So now, Chief, we got everything. Now what we should do is track the above down. So what I'm going to do is I'm going to hold the wire below. So I've got now this real pushable rail, right? Show me all the way up. See, so now I'm gonna go ahead up. See? I'm gonna push it into the pop. Now I know I'm intraluminal, right? All the way down, right? Now I'm gonna have Sachin undo the clamp for me. So now I'm gonna let it bleed here. I'm just gonna slowly pull it out. I know a lot of people viciously pull this out. Remember, you could injure the artery coming out, right? So we're just gonna come out slowly with this, right? So now we know we're intraluminal. Now I'm going to give a little dye. Okay. So remember, the beauty is, look, it's been 50 minutes, right? I agree. This is not bad for a tough SFA case, but now we really did the most challenging part here. So now we're just going to take a little picture. Okay, we're intraluminal, right? Everything looks good, right? So now we're going to take a Spartacore, right? So we take a safe wire. We're going to throw it down here. And now the question is, what do you want to do? So, you know, Ray already asked the question. So what are the options for therapy? What would you do, Chief?
Well, I mean, in this case, I would probably end up doing an atherectomy and then hopefully DCB, see how it responds, and then if need be, put a supera mostly in the popliteal, because that's where I'm concerned about the disease.
Well, the other thing we could do is use the 300 bare wire and put a filter down if we're expecting embolization, which may be a possibility. So okay, let's go over the options a little bit, right? So the options are atherectomy, angioplasty and stent, meaning DCB with stent, or you can do covered stent, and that's the idea. But okay, the first thing I think most people would agree with me, and I tell my fellows all the time, as you do, that there's no real definite rules in peripheral intervention because we don't have enough data to say that this is what you should do for this situation. So let's break it down into more logical approach, okay? So you're subintimal from above, you've dissected the baloney out of the popliteal. So now, yes, even though you're intimal because you went from below, you're probably gonna have to stent that reentry zone. You have a diffusely diseased pop below, okay? So let's assume we're gonna stent the pop from below. Number two is above. You've got a long segment SFA, definitely a TAS D. Maybe you're intimal, maybe you're subintimal. Remember, we were in a loop the whole way down. So with the V1, the V18 wire. So therefore, you know, you could argue, listen, you know, you stent the ostium, stent the distal, DCB the mid. Not a bad idea. So you know, I think at this stage, I would probably err on the side of, rather than doing atherectomy, is to go DCB stent. So my plan is going to be balloon the popliteal, and then go ahead and DCB the popliteal, place a supera in the popliteal of 5.0 if I can, and then up top I'm probably going to go ahead and place a couple of Zilver PTXs and then be done with it. This is going to be my general plan. So you can say, why not Zilver PTX in the popliteal? Well, let's go over the data. You have 1.9% fracture rate, so you can say, well, you know, the American IDE study had 5.7 centimeter lesions. Well, if you look at the Japanese PMA study, the post-market study, you know, the average lesion length was 14.7. all comers, including patients such as this, all runoff, ISR, severe calcium, and the fracture rate was still only 1.9% at 1 year. And in the IDE study, the fracture rate never changed after 1.9%, after 3 years never increased. So the misnomer that Zilver fractures is very, very important to remember. It's not that Zilver fractures. I think that there's a great amount of data with the Supera in the adductor canal and in the popliteal segment, and it is an FDA-approved stent for the popliteal region. So I think that it's probably wise of us to use a Supera in the popliteal and then go ahead and either do DCB plus something else, or we can do just Zilver PTX all the way up to the ostium. Now, limiting factors with the Zilver PTX is the lesion, the length of the stents that are available are only 120. So we're going to have to put 2 or 3 Zilvers. The other option could be is to DCB the whole thing and put an Everflex 200 all the way up. Multiple different ways of skinning the cat. I just think you have to know your equipment, you have to know the data, and you have to know what you're going to have to definitely do. Since there's a dissection in this case, at the re-entry point, even if you atherectomize and DCB, I believe you have to stent. Do I have the data to say that? No. I do a lot of cases, so I have some experience to say that, in my opinion, that's going to work the best here, so that's what I'm going to do. So guys, let's do this. So first thing I need to do is now, no filter. So first thing I need to do now is go ahead and decide what balloon is going to track down. So right now, I've got an 018, this is an 014 wire, you can come back up, an 014 wire, down. So now I'm going to get a 018 power cross balloon. So give me a 50, actually a 60 power cross all the way down. Actually a 50150. So I'm going to take a 50150. Now why did I judge 5 versus 6, right? So let's look at that distal popliteal now. Let's take another picture with Sachin. ACT is good, guys, for me?
Yeah.
Okay, give me a DSA. So I'm just going to inject. I want to look at that healthy segment of the pop, or the near healthy segment of the pop, right? So here we go. So let's look at that near healthy segment of the pop. So right above the collateral. Now remember, we were never there. So at that stage, I think it's no more than a 5, Vishal. What do you think?
No, I think you're right. It's no more for a 5.
So a 50150 power cross, it should be right there, or 200 if you have it, I don't mind. So we're going to go with a 50150 power cross, and we're going to land it around 11, right? So we're going to land it around 11.
Well, I guess I agree with your strategy of going ahead and doing DCB and stenting. But I guess my approach is a little different, which, I don't know, like you said, peripheral is an open field and you could take any algorithm and do it the way you want to.
Right.
But I'm a nothing left behind believer, so what I would probably do in this case is do a PTA and see how the popliteal looks. If the popliteal looks fine, I'll just DCB and leave it, because a re-entry, if you look, is more above the adductor canal in this case because we went from below. So we might be able to, again, depending on how it looks, and you're right, we probably might be very subintimal, which might need stenting. But I would start conservatively, balloon, do a DCB, see how it looks, and then do a focal stenting where it is.
I agree. Listen, those are just thoughts that we share. And I think that's part of the reason what's so much fun to collaborate with one another is to see whether we can do this, right, and get it over with here.
Right.
So the balloon is, again, we need to go to just 11 or 12. We're probably going to go to 12.
Nice.
Oh, I'm too far down? No, I'm okay.
I think that's good.
You should be okay. Yeah, that should
Right,
be
let's
fine.
advance the wire a little bit, guys. Shall we blow? Just don't want to lose. See how my wire came back here?
Yeah.
That's good. There you go.
Loop is even
So
better.
Ray is very good at railing, so we call him Rail Ray. So you can see here that we're just going to go with a 50. This is a 50 balloon, guys. 50150. So we're just going to go ahead and remember, be particularly artful in your balloon angioplasty. Go up, leave it up for a few minutes. Don't be a quote unquote coronary guy if you're a cardiologist. Really try to crack the lesions in the vessel. You can see here that we're just going. There you go. So now we're going to go up to nominal, right? What's nominal?
6.
So we'll go up to 8. So we're going to really expand this since we may put a Supera. So we're going to go ahead and go to about 8, right? And then we're just going to leave it here, and we're going to put our timer on. Reset the timer, Damien. So we're going to reset the timer. We're going to do 3-minute balloon angioplasties in each area, right? You can argue to do 5 minutes. We can do 5 as well. But I think 3-minute balloon angioplasties are reasonable. So we're going to go ahead and do 3 minutes. So right now we're at 7 seconds. So let's talk a little bit about some of the data that's available with these long segment lesions. So Vishal, you want to talk a little bit about impact in long segment lesions, and as well as Lutonix, DCB in long segments?
Right, so the impact data, essentially, they now have a 2-year data which suggests that long segment lesions, whether it be severe calcification or not, they have good patency rate anywhere from 87% and around that marker. So there is good data on DCB. Even Bard's Lutonix balloon has also shown to have great patency and reduced TLR at the end of 1 and 2 years. So we can, like PK said in this case, use DCB or even stenting depending on the anatomy. So nowadays with DCB being in an armamentarium is a great alternative or a great option for us to use if somebody doesn't want to stent or just wants to get away with stenting. So I think it's a very, especially in our lab, we use it a lot. Even in SFA CTOs, long segment, me and PK both. So
I think the data with Impact Global, really shows, gives you a lot of confidence in these lesions. So Impact Global randomized all real-world lesions. The long lesion cohort was 150 patients who had the ultrasound follow-up out to 2 years. The 1-year data, I think the 2-year may have been reported too. Yes, 2 years also been reported, like you said. So the beauty here is around 20 centimeter lesions to 25, greater than 25 centimeter lesions. Interesting thing is there's a 40% provisional stent rate. So the 40% provisional stent rate shows that even with provisional stenting, the DCB works. So there's no reason to worry about, you're going to leave something behind or don't leave nothing behind, because I was, like Vishal, a leave nothing behind kind of guy. However, it's not necessary anymore. So I think in this stage, even though it wasn't randomized, it was a core lab adjudicated, had a clinical events adjudication and committee, as well as an advisory board, a data safety monitoring board, a very well done registry that really showed that you can confidently use the impact balloon in these lesions. So down. So we're on 2 minutes 20 seconds, which is okay. Let's just be a little impatient because we're live. And then we're just going to pull this back. See, this is where you'd like a long 018 balloon. I know that Cordis makes a 300 018 balloon, which I think we should buy that for our lab. Go up here. So you can see here, we're going to balloon this segment again for a little bit longer with a 5.0. Probably, we're not so probably undersized here, Vishal, I got to tell you, because she's a lady, she's probably not that, she's not that, body habitus is not that large. So I think at this stage, we're going to leave this up again at 10 atmospheres for another 2 minutes.
I think a good observation to note here is the way Sachin goes up with this balloon. In coronary, we're used to just cranking it up high up, but in peripherals, you want to go slow and easy and see how the lesion breaks and cracks open. So if you can see, Sachin goes up to 2 and then slowly 3, 4, and then to the nominal pressure. So that's one good point to always be, especially to keep the PTA open up. So just an observation.
Right. That's a great point. So again, as you can see, our distal stopped bleeding basically. Everything looks really good. So we're just leaving it bleed. I don't put any power dressings on it. If it starts bleeding, we'll just hold finger pressure till it stops. We're going to watch this closely. As of this stage, there's no hematoma or anything around there. So I'm not too worried here with anything bad happening to this. So we're about just coming on about 2 minutes now, right? No, about a minute. Yeah. So want to leave another minute, at least minimum 2 minutes with the balloon angioplasty. So finally we have data both with long lesions with DCB. Obviously we have data with long lesions with Supera. We have data with long lesions with Zilver PTX. So we've got some good data. I think I want to throw something out here. Do you think in today's day and age, with the data that's present with SFA, that all SFAs should receive a drug-coated therapy before leaving any lab in America? I want to be very general and very dogmatic about it to see what you think.
Well, that's a great point. I mean, if you look at the work, especially done in the pathological slides, where they actually show the intimal hyperplasia with and without drug, it's actually proven that the paclitaxel drug really works, especially decreasing the intimal hyperplasia and the down the lane. So my thinking would be at least to line the vessel up with the drug, either by using the DCB or if you have to use a Zilver PTX, and then decide on your further strategy. So I would primarily use DCB in any lesions treated in the SFA, and then, like I said, do spot stenting, whether it be, or just leave it the way it is, or use Supera, whatever you like.
So Vishal, in your practice, do you find there's a difference between impact and Lutonix, or you don't believe that you should compare the two?
Well, I mean, I know there is data suggesting out comparing head-to-head between these two balloons, and it's shown that the impact is better in outcome as Lutonix. But for me personally, looking and following up with these patients, there is not much of a difference. Again, it all depends on the volume. If you do a lot of cases, probably down the lane you might see a difference, which these registries did. But not personally, though, unless you have another experience.
Well, I totally agree with you. I know that both companies say that their data is better than the other. I think there's no head-to-head data. I know that Jaffer Goldzar, our good friend in CBC in Chicago, and his group is going to do their only, they're doing a head-to-head randomized study with Lutonix versus Medtronic. You know, to me, I think the proof of concept here is that these balloons work. They work better than regular PTA, that drug has an effect on the SFA, and I take it at that. I think, you know, beyond that, I think convenience sake, you know, Lutonix has a 150 balloon. They have markers on their balloon so you can easily measure. Medtronic has, you know, very trackable, very good balloons. You know, you know, as far as safety, they're both equally safe. You know, Lutonix has there's some embolization with Medtronic, but we know that in clinical practice, we've never seen any of that. So, you know, I really believe that at this stage in a claudication population like we're treating with her, I think either balloon is very valuable in your lab to have. So I think, you know, having a drug-coated balloon in your lab will clearly help you in order to be able to do that. Down?
I guess the only difference to note is the Lutonix balloon has a
sorry.
paclitaxel concentration of 2 mics, if I'm not wrong, per millimeter, while the impact is 3 mics per millimeter square. So I don't know how much that makes a clinical difference, but that's to be seen, I guess.
Well, the interesting thing is the Stellarex balloon is coming out with our Illuminate study that you know we're the leaders here in New York, having run this study and enrolled the most patients. So that's going to be a very interesting thing. And then when we have 3 drug-eluting balloons in the market, the question is going to be, you know, which one is the one that's really going to work, and what's going to be your option. I think one good thing is the cost is going to come down, and the second thing is I think we're going to have more choices to go ahead and work. I have good news. Marichu's here. Hi, Marichu. We're still missing Liz. We'll find Liz soon. Okay.
All right, let's see what the results are.
Okay, that's fine. Down. Let's just, for the sake of time, down. So let's take a look. Let's walk this out once it comes down. So now we're just going to take one long picture. Very good. We're just going to watch our distal wire. That's good. Just don't advance the wire. Yep. So Ray is going to go ahead and put me on DSA while Sachin walks this out. Okay, good. We're going to low mag here, guys. And remember, we dilute our dye 50-50, which is great, you know. So we're just going to take a shot now.
Wow.
We got some flow down. Can't really see much, but that's okay for the pilot shot. And then okay.
Looks very nice.
So ostially, we have some issues we have to deal with. And distally, again, I'm going to take another picture here to really see it. Go ahead. So very nice distally too.
Yep.
So the issue now is we're going to go ahead and do some DCB balloon angioplasty, right? Huh? Huh? Oh, you want to go back to the ostium? We're good.
Yeah.
Okay. So we're going to go back and hit the ostium.
You want to do this?
Or do you just want to use direct DCB on
Okay.
the
I
ostium?
would probably just DCB the whole thing, see how it looks.
Okay.
Yeah, or maybe Zilver PTX the ostium. We'll figure it out.
Sure.
So give me a DCB, guys. Give me a 50-120 impact.
I think the biggest concern in all these SFA CTO, especially on my personal opinion, is the ostium. So if you don't treat the ostium well, you'll see these patients come back with closure of the stents, either ISR or even acute limb, because the ostium wasn't treated well, like how we do with the coronaries. So I guess, like Sachin said, special emphasis on the ostium is very important in these cases to maintain the patency. But that's again on just personal.
No,
level.
I agree. It's all anecdotal at this stage. I think there's a school of thought that says in these long segment CTOs that you should stent the ostium, stent the distal, and leave the body with just DCB. You know, I really don't know what's right, what's wrong. I just know that we need to do it's hard to get all data on every little subset, you know, because I think the peripheral cases that are being done are just not enough for us to answer all the questions that need to be answered. So I think there's a lot of need for single center anecdotal data that's going to help guide, you know, some of the therapies. So I think that it's not unreasonable to say that, Vishal. I agree with you. It's definitely not unreasonable to say that.
I think we have a fresh, new, excited fellow who's coming, so maybe he can work on it. Let's see how happy he is.
Yeah, he's going to be clinically busy, though. We'll see. We'll get somebody to look at it. Railway. So we can see here comes a balloon. So now I'm going to go a little bit out across to about 13. 14. Right about there.
So what size and what is
it's a 5.0 again. So
That's
we're just,
good.
yep, I like that because we're just going to go from normal to, we're going to start from, we're going to have a little landing zone that's normal here.
It's a DCB, right?
It's a DCB now, 5.0 120. Now get me a bunch of 6.0 120s, guys. So we're just going to go up to 2 minutes. Go to nominal. So nominal is 8, right? So we're at 8 now. We're going to leave it up for 2 minutes. So I just ask you guys to be a little patient while we do this, because I think that, you know, as we know, watching DCBs go up are not fun, but I think the end result will be a very worthwhile result. Give me 2 more 6.0 120s, please.
What's your sizing strategy on DCBs and vessel size? Do you keep it 1:1 or
Well,
leave it even more bigger?
I think we learned from the Lutonix data that vessel to balloon to artery ratio is very important. So probably 1.1 to 1 is probably the right balloon to artery ratio. You know, the problem with that is all the trials only recommended visual estimation of the size of the vessel.
Right.
So if you go with visual estimation of the size of the vessel, then the Medtronic and the Lutonix balloon both should have the same data. But Lutonix was able to tease out from their core lab that when the balloon artery ratio was greater than 1:1, their patencies were even better. So I think a simple rule of thumb would be 1:1. If you go 1:1 with the balloon angioplasty, I think you're going to be fine with the result. The key is allowing the drug to work. And the key is, how do you look at this balloon? So if you look at Germany, and they probably taught us the most out of these balloons, they look at it as it doesn't matter, you can dilate with this balloon and leave it. So in America, I think what we're starting to do is treat this as an actual therapeutic agent. So what we do is we actually prep the vessel with either atherectomy or a regular balloon or whatever it may be, and then use this as a delivery agent to go ahead and deliver the drug, which is exactly what we're doing in this case. So generally 2 to 3 minutes is enough for the elution of the drug. So we're going to leave it up for about 2 minutes now. And what's really important is to avoid geographic miss. So you can see right here, what we're going to do is we have a glow tape across the vessel. And then what we're going to do is we're going to go ahead and now store the image on the right side of the screen. We have 2 screens here. And when we do that, now we're going to make sure there's a 1 millimeter overlap of the balloons so that we're not going to have this. So right now we went ahead, we did a prolonged 2-minute balloon inflation, and like you said, we're going to try to spot stent if that's what we need. We know we're stenting the ostium. There's absolutely no question we need to stent the ostium. So we'll go ahead and take a look here distally later on. So right now I'm going to wait for the balloon to come down, the bubbles to start moving. Just going to watch our distal wire, and then we're going to walk this out.
So what's your stent strategy for the ostium, specifically when you've used the DCP and layered your vessel with the...
Oh, it would have to be a bare metal stent. I think at that stage, you know, any bare metal stent, either the Abbott Absolute Pro or the Everflex of EV3 you can use. So it's really not anything that you need to worry about. So, you know, if you want to just say, hey, listen, I'm going to stent it and I want a drug-coated stent, then I would not DCB and then put a drug-coated stent. So maybe we'll decide together. So maybe we'll stop a little short, prep that ostium with a regular balloon, maybe a high-pressure balloon, and then go ahead and put a long Zilver, maybe a 120. That may not be a bad idea either, you know. So these are the options I think for the operators out there. You know, one is you want to do therapeutic agents that you know work, which is what we're doing here, and 2 is you want to go ahead and do the other part of it, which is treat appropriately based on what's needed and based on the anticipated mechanism of failure. So here the anticipated mechanism of failure in the ostium or the distal is going to be dissection and recoil. So remember we're around 31 or whatever, maybe 1, 2, so I'm going to go to around 30, 31 here. So if Ray gives me a rail, we'll get over there, right around there. I think that's pretty good. And now we're going to go, no, maybe a little bit forward, right? Yeah, right there. That's good. So we're going to go ahead now, and we're going to go up with the balloon. So the balloon is going up here. Now this is a 6.0, a little bit bigger, a little more proximal. So we're going to go all the way up to 10 or so. Yep, and Mrs. Hudson is noticing that there's a waste. So this is the area of the vessel that was slightly calcified. By no means heavy calcium. And these vessels were enrolled in the study. Go to 10. So we're just going to go ahead and again, we're going to save this on this side, guys.
And what about the dual antiplatelet therapy in DCB? To give it 2 months, 3 months?
Well,
longer?
with DCB, the IDE study showed that we're going to leave it on for about a month is all that's necessary. Zilver PTX 3 months. So generally speaking, I don't recall if this lady has any coronary history. If she doesn't have any coronary history, we're just going to leave this on for 1 month if we don't use the Zilver PTX. If we use the Zilver PTX, then we'll go ahead and leave it on for 3 months. So you can see here now, again, we're watching paint dry. So let's talk a little bit about what we're doing on July 4th weekend. No, none of that. See, Marichu's hitting me with spitballs to keep quiet. So okay. So now, the issue now is, I can think of the important technical aspect is the use of glow tape. We see it too often that the geographic miss occurs where people are not using glow tape to be able to identify where the DCB is. Until we get one DCB that covers the entire length of the SFA, we are going to be forced to have markers to let us know where we are. So it's very, very, very important for you out there to respect that and understand that if you have geographic miss, you're going to have high rates of restenosis.
Just a quick question in regards to the ostium stenting. Do you like to bring it up or into the CFA like a couple of struts, or you're very cognizant about the profunda itself and keeping it right the ostium? What's your approach on the?
Our surgical colleagues, are very respectful of profunda, which I totally agree. But in my career, I've done maybe 7,000 cases and probably a good amount of ostial SFA stenting. And I can tell you that in those cases, I've never seen a profunda that had no disease restenosed because of an SFA stent that was partially across the profunda. By definition, in order to cover the ostium, you're going to have to come at least 1 or 2 struts into the main vessel. We learned that in the coronaries. So I know it's not a coronary as a lot of people would say, but at the same time, the same vessel anatomy is there. So if in order to cover the ostium, you have to come into the main parent vessel at least by 1 or 2 struts, then clearly you're going to have to come across the profunda at least 1 or 2 struts. We try not to completely jail the profunda, but there are times when you have no choice because you are so close. Well, it came back?
No.
Where it's so close, where you have no ability to go ahead and stent across the profunda. So I wouldn't worry about it. The area where I would worry about it is if I have very, very tight profunda stenosis and I'm placing an SFA stent across it. What about you, Vishal, in your practice?
No, what I try to do is get at least a steep angulation and orthogonal views to really define my ostium. And again, I'm again translating my coronary skills into peripheral. So I would stent at least a couple of struts into the CFA to just make sure the ostium is definitely covered. And like you said, the only time you're really concerned is the profunda ostium. If it's disease, I'll probably just do a small balloon dilatation to make sure there's still flow patency down it after stenting, and then stent from SFA into the CFA.
Right.
You have to take the sheath a little bit.
Mm-hmm. I think our sheath came back a little bit. Show me the sheath a little bit, guys. So again, these are the kind of things that sometimes occur. I think our sheath came back more than a little bit. Show me a little higher, guys. Yeah, our sheath is way back. Show me the sheath. Okay, so now we're just going to use the balloon as a rail and just go down slowly. The rail, please. I think you have to be very cognizant of this stuff from happening. That's enough. Rail now. Okay, now I'm going to go down. So I need to go to about 20. Yeah. So please shutter in, reduce our radiation. Okay, good. That's 20. Let's go ahead and inflate this. Get us a nitride chew.
Put a zilver for the ostium.
Yeah, we're going to zilver the ostium now. So we're just going to go ahead and use the same balloon to prep after we deploy this. And we're going to do 120 silver or 100 silver? 120, huh?
120.
We're going to overlap the DCB segment. 60120 silver.
So just again, a query. For your pedal accesses, do you just hold pressure or you take a small balloon down and occlude the entry point
Timer.
for precautions, or just leave it the way it is and it just closes by itself, especially when you're anticoagulated right now?
Well, for pedal access, like I said, we let it bleed, and it stopped on its own. So we just let the thing, we'll let it bleed, and then later on we're going to go down Vishal and give some nipride. That's why I already asked Mayor Chu for the nipride, and we're going to go ahead and inject some nipride and verapamil that down there, and get rid of the spasm. So there is going to be some associated spasm. And especially when you put dilators in or even catheters into that vessel, you're going to have to assume there's going to be some spasm. What we've noticed is even if there's some residual stenosis at the area of entry, that over time, that this is really just a vasospastic response, and that this will get better. So I don't want everybody to get worried that, oh my goodness, this is not getting better. So now, do not worry about it. Do not go down there, re-balloon it. The time where you would re-balloon it or balloon tamponade it is if you continue to bleed despite pressure with your finger. Then I guess our next step would be to use a gauze with some tape wrapped around in a tight manner. If you really want to spend money, you can use a radio band to go ahead and do it. But to us, we have not had that issue. If it continues to bleed despite pressure with gauze, then I would go ahead and go down with a small 014 balloon, tamponade it for a few minutes, and then allow it to heal. So we're just going to go ahead and just do a roadmap to see the ostium, right? After the balloon. Well, we're going to have to balloon the ostium with this anyway. So once we deliver the drug, this balloon becomes a regular balloon. So what we're going to do now is just use this balloon to pre-dilate for the Zilver PTX and the ostium, and then go ahead and then deploy the Zilver PTX. We may still have to deploy a superior distally, which we may have to, maybe we should take a picture.
Right.
But I think what I'm going to do here is be confident and go ahead and deliver my Zilver PTX proximally and then be done. So it's right at 2 minutes now. We're going to come down with this balloon. And we're coming down with the balloon, and I'm just going to have Ray give me an osteal injection so I can see.
I'm pretty impressed the way Sachin has kept the table clean.
Yeah, it's actually true. Very good. So now
Nice.
we're just going to pull this back up to the ostium. Right, I'm just going to go across the ostium a little bit, right to that spot, and just balloon it. So you could say, well, Prakash, you're jailing the profunda, but the truth of the matter is this is a very close profunda SFA situation here. So you can see here, even with that, it's recoiling out.
Right.
So I'm going to have to pull it back. Down, please. There it goes.
Oh, it popped.
Okay, good. So now we're going to leave this up. Go to 10, 12. So we're really going to expand this here because we're going to have a lot of recoil at this stage. So we're going to go to about 12. We're going to leave it up for about a minute. So we're at 3 minutes. We're going to go to 4 minutes. Then we're going to take a shot of the Zilver, and then I'll let you know what we're going to do. We're probably going to go ahead and sign off and then finish it up and give you the final picture. So let's see how this looks here. So I think one of a couple of the other things that we've learned is the balloon angioplasty technique is very, very important. You really want to go ahead and keep that balloon inflated for a period of time, to really allow for lack of recoil. So right now, we're going to leave this up for a minute, even though it's a slow process. It's a boring process for us to watch. But I think that the being methodical is going to result in better primary patency for us in the long run. So I'm just going to go ahead. I've got 30 more seconds, and then we'll just go ahead and come down with this.
We're shifting anything over to the front.
Yeah, that's what we talked about. I don't think there's any plaque to be shifted. I mean, God willing, nothing shifts. Like I said, in my experience, I haven't had that kind of bad luck happen to me. But again, anything is possible. Anything is possible. Okay, down. So we're just about a minute now. So Sachin is going to go ahead and bring this down. And then we're going to take a quick road map, and then we're going to stent it with a Zilver. Our primary intent is to stent with a Zilver here, so I'm not even worried. I'm just going to go ahead and just load it and just get ready to stent it.
Sheath.
I got the sheath here.
So you're going to use a 6-0 long silver.
120. I'm going to 6-0, 120 silver. Like I told you, I think there's no reason to go with the 7. She's a little old lady, and I think she's going to do fine with a 6-0 silver PTX here. We're going with 120 here to ensure enough coverage distal. And the nice thing is we have the new silver roller bar,
Right.
which has just been released by Cook, which we're very happy to have. Rail guys. So I know one of the criticisms of this fine. One of the criticisms of silver was that it was hard to deploy because of the stiffness, but this roller bar has made life a lot easier for us older generation folk with not enough hand skills. Oh,
No, I think it's a great system, especially being a triaxial
roadmap now.
system.
Let me
The
just go in
movement
distally a
is the
little bit.
least, so
okay,
it
roadmap.
really works well.
So we're just going to take a picture of the just a road map of the ostium. Okay, now we're going to have Sachin go ahead and deploy it. So we got a little pinch in the profunda. You see that?
Yep.
So, I'm just going to monitor that. I'm just going to deploy the silver right there. I have no choice here. So we know it's not going to move. So it came back a little bit. I'm just going to go forward a little bit. I think that's a good spot right there. Let's deploy it. Let's not move it. I love it there. I really love it there. So he's just going to get it started. Oh, it's coming back. It's coming back. Okay.
Like that?
Yep, I like that. Mm-hmm.
Oh, no, good.
So if he doesn't get it right, he doesn't graduate.
Well, he's pulling on it a little bit. He's definitely pulling, I can tell you that. Go ahead.
Nailed it nice.
Look at that.
Oh, congratulations, Sachin.
That's Sachin Jain. Right? To all of you out there, he's coming to a town near you. So low mag, please. So we're just going to go ahead. I told you, Vishal, I'm not worried. I don't think there's anything you can do here. Low mag completely.
There are no filters
Give me
to
some
pull.
nitride, Chooch.
There is no laser to get stuck. Everything is good.
Give out.
So I'm just going to go ahead and flush this with nitride here.
I think we nailed it nicely.
Go ahead, guys, flush it down. Flush. So we're just going to flush all the nitride down into the distal vasculature. Make our vessel look good.
So
PSA? 48
cc
mag?
80 cc of contrast.
Huh? 80? So far, 80 cc's of contrast has been given.
Beautiful.
I've been told here. DSA, great. Show me the profunda flow as well, so this way everybody at home can see the profunda a little wider. Good. Ready? Okay, let's do that again because there's a lot of saline there.
Looks
So
nice.
beautiful,
Beautiful.
good Timmy 3 flow in the profunda, Timmy 3 flow in the SFA. Let's look distally here. Oh, thank you. Okay, ready? So again, one of the things you're looking for is, does the SFA beat the profunda down? Certainly does, right? So maybe a little touch-up balloon angioplasty there that we'll do offline, right? More importantly now, the next thing is to assess my popliteal region. So again, looks pretty good. I'm going to reassess it. I may or may not stent it, but I think for the sake of time, we're just going to keep moving here. And we're just going to show you the runoff here. So you can see there's your AT. Again, AT's got a little bit of slow flow, so we might have to go down there and do a little bit of touch-up, which I'm going to do probably now, not offline. So give me a 01A Trailblazer, guys.
Okay.
Was that the AT that wasn't filling? That was AT, right?
Yeah, that's
Yeah.
how the wire is.
Okay,
Right.
good. So let me see, Flora. So we're going to get the AT down. We're going to get this wire down there here. So it could be a dissection, could be something else, but we'll see. Most likely it's just spasm.
Yeah, I think that's what it is. Probably distal spasm, so your runoff is...
So I'm just going to run this wire down there and just do a little. Yep, looks like right there we're having a little issue here. So, okay, give me a Trailblazer and give me a fielder wire, guys.
I'll probably go down with the catheter and give some more
Well, no,
vasodilators.
I'm going to cross this with command wire.
Right.
And then take a look. Now, it's very rare like this happens, but again, we'll see. We'll see what we're dealing with.
I got it.
Rail,
1 second.
mag up, off DSA. Make it coronary.
Yeah, ready?
Okay. Don't let that wire go. Now remember, this is a very poor wire. This is a Spartacore wire. It's not going to cross anything usually. Okay, wire up. So give me the command. Made a curve. Okay, give me a curve maker. Give me some nipride shoots.
Yep, that's right.
Mag up here, guys.
Give 100, 2 cc's.
Oh, it's actually a little higher than where I got access, where it's getting stuck.
Right.
So maybe there's some plaque there, who knows. Well, it's certainly not behaving like anything major here.
I think it's just a spasm right there.
So let's just go, let's check our distal vessel. Nipride, guys. Thank you. 100 mics of nipride going in. Make sure I get blood back to make sure I'm not in a dissection plane. I'm not in a dissection plane. Flush, please.
Flush here, flush here.
And give me some dye and show me DSA of the foot. Right. Contrast.
Some more nipride, guys.
More nipride, guys. Okay. All right, we got all sorts of trash on us, but
It's all underneath.
it's all underneath. But Damien, can you remove some of that, whatever that is? It's probably the blood pressure cuff or something. You see the foot? You got it?
The CTO. The look should be better.
Much
Yeah,
better.
good.
Thank you, Damien. You don't have to do anything now. Very good, right? So good flow into the foot. So we have an embolized. I'm going to a little twig there. I'm going to just pull back. Okay. And then now I'm going to give a little more nipride chooch. So this is important for everybody at home watching. You know, this is a claudicant. You don't want to go back and give them CLI, or you don't want to create any issues here. So you want to make sure your distal vessel is good. So what I'm going to do is just give a little more nipride. I'm just going to pull this back. Right, I'm just going to continue pulling it back to the proximal area, just delivering nipride the whole time. Right, now I'm going to inject from there. I'm going to give saline, flush the whole thing. You know, you can give nipride, you can give papaverin, you can give whatever you'd like, really. It's not an issue. Don't be afraid to give it. Nothing bad's going to happen, but at the same time, don't leave it. If you have a true cutoff of the vessel, you need to make sure that nothing has happened like we did here.
Contrast.
Yep, so lower mag here, Ray. Okay, this is good. A little higher, maybe. We know the foot's good, so let's look a little higher. Good, right there is good. Okay, ready? So we're just going to make sure that we haven't dissected. Hopefully we haven't. Okay.
I think it's just a spasm that keeps.
Yeah, well, it's interesting. It's just not going past the access side. There's your spasm.
Right, it's all spasm.
So it's a lot of spasm there. Let's mag up there, Ray, for me. I'm just going to go down with this. Just going to go down with the catheter. You see the spasm right there, guys? See that? See as I go through, you see that? That's all nothing but spasm. So give me verapamil, Chooch. So I'm going to give some verapamil. Now remember, these vessels will thrombose, so you have to spend a little bit of time here, you know, on these vessels. Don't be afraid to spend a little bit of time giving some pharmacotherapy. I know we're a little bit over time here, but I think this case demonstrates so many things that I think it's worthwhile for us to spend a little time here. Because normally I do cut off for the sake of time, but I really want you guys to see the care that you have to take in these vessels. You know, so we're going to give the whole nipride, the verapamil here. Give me a nipride too, Chooch. So I'm just going to go ahead and just pulse it down there a little bit. See? Just pulse it down there. I'm going to pull back a little, go forward a little.
100.
Just pulse it down there. You know, it's normal for the burning to occur, so don't be afraid of that. And then I'm going to go ahead and flush this verapamil. And then I'm going to go ahead and take a picture. The whole idea is you want to leave her with what she came with.
Right.
You know, even if you're not through the SFA, That's
No, no, no,
okay.
this is a
You don't want to leave her with a one
Right,
vessel when she came in with 2 vessels. So, now I'm going to go ahead and give nipride. Again, I'm pulsing it through, right above to below. And then now I'm going to plush this through with saline, and then we'll take another picture. And if we have flow, I'll just close and I'll let you know what we're going to do.
Awesome. That looks great.
I know that this case took a little longer. It's a very complex case, though.
I think a lot of learning points, a lot of steps, a lot of strategies,
Yep.
and a lot of different techniques
DSA.
used here, which is actually great for success of a case. You have to know these plan B, C, and D. So
There's your spasm
Yeah,
site. See, notice it's spasm, so I'm even going to pull back a little bit more, just to make sure there's nothing going on there.
beautiful.
See, guys, that's nothing but spasm.
Right.
So now I'm gonna before we finish offline, I just want to step forward and just talk to you a little bit about this. So I think in summary, you have a case that this camera, I guess. Okay, you have a case. No, that camera. I'm on that camera. So you have a case where clearly you have an ostial LSFA occlusion with diffuse disease in the distal. So this case really outlined to you with Vishal, how to identify the ostium, what are the wire choices, what are the catheter choices. Then how to traverse this difficult complex lesion using smaller wire gauge wires. And when you get to the distal edge and you can't, how to get pedal access. Well, we failed doing ultrasound. Our ultrasound machine is old. We got it the traditional manner with the regular stick, got into it, we went up and we got it crossed, showed how to cross, externalize the wire. We did DCB and stent, and then we dealt with the spasm in distal. So I think it's a very good case that it covered a lot of different things. There's a lot of good teaching points in this case. I think it's applicable to cases like this and to other complex cases you face. So I want to thank online Sachin for all the hard work he did this year. I think his fellowship has been one of the best here at Sinai for me, and I can tell you that we're going to miss him dearly. But he's coming to Houston, so everybody in Houston is lucky to have him. And I want to sign off here. Vishal, thank you for your support during the symposium, and most of all, want to wish everybody a good 4th of July weekend, and we'll see you in July. So thank you again. Have a good one.
Thank you,
All
PK,
right.
for a great case and an excellent result. Just for the viewers, don't forget to go onto our website, peripheраlinterventions.org, and watch this case, which will be archived by the end of the week. For our previous cases, again, you can go to the archive section and watch them and review them at your own convenience. Just to let you know, the next case is on July 27th at 8 o'clock Eastern Standard Time. We'll see you then. Till the time, have a pleasant weekend and a great 4th of July.